Welcome everybody to this session. A problem shared is a problem halved, and today we're looking at patient safety, so I'm really pleased that you're all here. So welcome to everybody that's in Glasgow. It's been an amazing, well, this is the third day, isn't it? And to everyone joining online, this session has been live streamed, so I hope everybody's got their hair done and their makeup done and everything else like that. Recordings of the session will be available in 10 days. If you're watching online, can you please put your questions in the box underneath the live stream? And for us in Glasgow, can you please put it through Slido and the details on screen. I want to thank the session sponsors, Becton and Dickinson UK. And if everybody can make sure your phones are on silent, that would be very, very useful. If for some reason there is an emergency, an announcement will be made and we will ask everybody to exit. And the muster point is between SEC Centre and SEC Armadillo, and no one's to return unless there's an official announcement. So now I want to introduce our speakers to this session. First is Vicky Hill, who is the Quality Assurance Manager at St Columba's Hospice in Edinburgh. So welcome, Vicky. And Vicky has over 25 years experience of working in clinical and quality roles in palliative care. Next speaker will be Laura Speight, Head of Inpatient Unit at St Gemma's Hospice. And Laura has a 20-year nursing career starting in oncology and has worked at St Gemma's Hospice for 17 years and is currently Head of Inpatient Care, leading the nursing, family support and spiritual care teams. And last but not least is Dr. Annabel Howell, who's the Medical Director of Children's Hospices across Scotland since February and has had a career spanning psychiatric intensive care units as a GP and as a palliative care lead in the Borders. So welcome to all our speakers. I also want to introduce Julia Russell, who is sitting there in the front seat all by herself, yes. And Julia is the Senior Clinical and Quality Improvement Manager of Hospice UK. And my name is Karen Taylor, and I'm Head of Clinical Services at Martlets Hospice in Brighton. So now I'm going to hand over to Vicky.
Good afternoon. I'm a bit shocked, I have to say. There are so many people here, which is just amazing. And for somebody who's worked in governance and quality for about 15, 20 years, it's wonderful to see so many people here. So, maintaining and sustaining improvements in patient safety. So, first of all, I just want to say thank you very much for the opportunity to present today and to share with you just some of our experiences and learning with what we've been doing to refocus and refresh our approach to patient safety. So our current hospice strategy centres around 3 themes: create, empower and sustain. And these are central to all our strategy ambitions. So in relation to patient safety, we wanted to create systems to support staff in delivering safe and effective care. We'd introduced an electronic risk management system back in 2019, which enabled us to report and manage incidents in a streamlined and more effective way, and also supported us in gathering a lot of data, a wide range of data. We wanted to empower staff. We wanted them to learn from incidents, and very much be an active part of our developing a positive safety culture within the hospice. Sorry about that. Wanted them to be part of the active part of developing a positive safety culture. So we created a patient safety meeting structure, and we also reviewed our education delivery. Sustaining any changes in clinical practice is vital, and especially after that initial excitement and energy has possibly waned a little bit, or if energy and enthusiasm had been directed to other projects. So I'm going to start just looking at some of our data. So here is an example of some of our falls data over the last 2.5 years. And this has been created by our hospice data analyst. So as you can see from the chart there, our average, around 5 falls a month. Normal range we'd expect to be below 12. So numbers aren't huge, which is good, but still gives us opportunities to learn and develop. There's a few things just really in the graph that I want to highlight. So the moments where the data just presents that opportunity to stop and question. So you'll see April 2020. So there's nothing really unusual about April 2020. The numbers don't exceed the upper limit. They don't raise a concern. There's nothing there to prompt us to be curious. But at that time, 2 of those falls had resulted in moderate harm. So the team engaged in reflection and learning. They refreshed their knowledge and they increased their confidence by revisiting the online education module and also going back to the policies. This was really early on in the pandemic, when clinical teams were adjusting to the infection control and prevention measures that were being implemented. The opportunity to reflect and learn supported that refocus of this area of patient safety in the light of the new restrictions. If we look at November 2021, that's the peak. So high level of falls, not what we would expect in our normal. So these falls were experienced by a few people. However, there was one person who had experienced a large number of falls. They had a history of frequent falls related to their condition, and we knew this before they were admitted. Frequent risk assessments were carried out by our multidisciplinary team to ensure that we had everything possible in place to reduce the risk and also to enable risk. Unfortunately, the patient continued to fall but experienced no harm. The other bit I just wanted to point out in this graph, if we look at May 2022, we don't have any falls. Fantastic. Great, we've got no falls. But we do need to ask questions around our data. Is this what we would expect in our patient group? So you need to ask questions around, do our staff know how to report? Do our staff know what to report? A question I always go to is our reporting system working? Is it broken? Or are our staff too frightened? Do they think they'll get blamed? So after asking all our clinical teams all of this, we did indeed have no falls that month, and the system wasn't broken and our staff were reporting. But we must use clinical curiosity to ask, is the data telling us what does real life feel like and does it match up? So looking at medicines, another area of patient safety, and again this is some of our trend data over the last 2.5 years. So again, medicines sitting below what we'd expect, nothing to worry about. And then in September this year, incidents increased to 12. So after investigation and reviewing the data, we identified there was 2 incidents relating to the administration of oral chemotherapy. The incident was staff didn't follow policy. There was no harm resulted from the incidents, but an excellent opportunity for learning by the staff involved. The organisational learning here is that we need to flag this up as part of the induction process in a much clearer way. In addition, in relation to this incident, we received a reflection from one of our senior staff who had wished to reflect on their role in supporting their team and the safe administration of chemotherapy. This wasn't an organisational requirement, but a personal need for that staff member. An indication of open and honest culture, feeling safe, and a demonstration of excellent leadership. If you only look at the trends, your stop moment is likely to be September 2022, when your numbers go up. But as you can see, we've had a number of different learning and improvements that we've made out with that time. And this is just a small amount of the improvements. So we have, we're currently looking at discharge planning education, because we were seeing a trend of an increase in incidents at that time. We've reviewed our remote prescribing policy, and we've shared that at our safety briefs. And we've also looked at changing the time of the administration of dalteparin from 5 p.m. to earlier in the day. And this was as a result of fairly frequent omissions at that 5 p.m. drug time, which we all know is really, really busy. These aren't massive big changes, and they don't need to be big changes to make a big difference. One piece of work that we did take forward, which I think is really important, was following feedback from our staff about the reflection process following medicine incidents. We've worked together and co-produced a policy for the management of adverse medicines incidents. What this has done, it's opened up the conversation between nursing, medical and quality assurance teams. Again, promoting an open culture, not hindered by fear, but promoting working in partnership with shared understanding of roles and responsibilities within this area. Empowering staff to be a key part of continuing to embed patient safety at a clinical level is vital. For us at St Columba's, the patient safety meeting structure has been central to this by providing a regular forum to discuss, review and action the information and the learning gathered from our incidents reported through our fairly new electronic risk system. It's been a really interesting journey. As you can tell from all the PD, SE cycles, there's been lots of planning and doing. It was initially set up to support ward managers in reviewing patient medicine incidents. It was about promoting and building a curious mindset and increasing ownership of patient safety initiatives and improvements within the inpatient setting. But the remit expanded. And we often do that, don't we? We start something and lots of things get added in. So, as you can see, lots of things get added in. The falls was added, pressure ulcers were added, support plans for medicines was added. And then there was a stop moment at PDSA 5. We had to stop. The meetings were getting busy. There was limited time to follow up on the actions between the meetings and the opportunities to discuss in depth and identify the learning were being negatively impacted. So we needed to rethink and refocus and refresh our approach. What we did was we met less. We looked at the other groups that were meeting in the hospice, and we amalgamated our falls and pressure ulcer groups into our patient safety system structure. So the groups are meeting less. They've got more time to action what they need to do. So maybe in this case, less is very much more. No doubt, I think there'll be many, many more PDSA cycles in this area, particularly as we develop the link roles within the patient safety areas. So, in order for engagement to be embedded in day-to-day practice, incident reporting and risk needs to make sense to staff. So we have reviewed our education. We deliver instant reflection sessions for managers, and we'll be delivering keeping people safe sessions for new managers moving forward. This will be key in developing clear roles and responsibilities and to support clinical leaders in creating a culture that is open and open to learning and improvement. All staff have annual sessions on risk and instant reporting. By linking real life and increasing accessibility of all staff, all roles, all grades, we can hopefully improve patient safety throughout the organisation. So staff training a few years ago included the journey of an incident form using popular game shows. There was 11. We used 11 to demonstrate that. If anybody, there's a clue up there to one of them, and if anybody wants to know the other 10, please get in touch. I was so tempted to do quiz show bingo here today. But it is something about trying to get something that makes sense and hooks into real life. So, sustaining. So we've discussed what we've created in terms of a system to support patient safety. Arguably, that's the easiest step. We're very good at creating meetings and forms and all sorts of things that, even though is a difficult step, is arguably the easiest one. We've tried to empower staff to continue to create a culture that's open to learning and improvement. So when it comes to sustainability, sustaining patient safety initiatives, you could say we've ticked some boxes. But we do need to ask that all-important question, are any of these effective? So you need to remain curious and you need to ask, what is the data really telling you? What does an increase in incidents really mean? Does it mean that we're more safe because we have more opportunities to learn and improve? And does it indicate an open and honest culture? If incidents reduce, and often we see that as a celebration, we want incidents to reduce. Actually, you have to ask yourself, are staff writing to report? Do they know what to report, how to report? And again, back to, does your system work, whatever system you have? It is vital to identify all opportunities to learn and improve, both for individuals and organisations. Based on the trends and the numbers, based on the narrative and the story that gives content and meaning to the incident, but most importantly, based on what will make the biggest impact on the care and the safety of our patients. Thank you.
Hi everyone. So I've been asked to talk about why we do audit, how it impacts quality, and to discuss any barriers to implementation of any change and learning that comes from it. I'll also aim to talk about how we learn from incidents and sustain change. So I thought I'd start by giving an explanation of what audit is. As the definition states, audit's primary intention is to improve quality of care, which usually follows a cyclical process, which often brings about change. Audit provides good governance and is essential for measuring performance and achieving high standards. So at St Gemma's, we are committed to providing the highest quality of care by providing an environment where clinical audit can be supported and sustained. We have a group called Evidence-Based Practice, which meets monthly, usually face-to-face. The membership of the Evidence-Based Practice group is multidisciplinary, including admin support, who hold us all together. Staff at St Gemma's are encouraged to understand why we practice in the way we do and have confidence to question and challenge each other. We review any audit proposals, monitor guidelines and question practice. Another forum for learning and sharing of information is our monthly practice inquiry meeting, This is a clinical forum which brings together clinicians from across the hospice to consider developments in palliative care and their impact on care at St Gemma's. An example of this could be a colleague who's done a piece of research as part of a course and they come to share their findings, often initiating changed clinical practice or implementation of a new tool. Both groups provide open discussion about the integration of theory into clinical practice. We have introduced an annual audit plan which identifies mandated audits, which are those that we all probably carry out, such as hand hygiene, infection control and monitoring of pressure injuries. Then we also have a schedule for the more ad hoc audits that we call evidence-based practice audits. These are those that stem from a specific interest, previous results that identify a change or a need for a re-audit, or from specific results where an improvement or change is necessary. These audits are done following the cyclical process previously discussed and can be seen as everyone's responsibility. Our audit plan identifies a lead person who is responsible for ensuring the audit is done, but doesn't necessarily carry it out. For example, the infection control audit across the IPU must be done monthly. So it's an audit that's planned in advance and a designated person is identified to carry out that audit at a specific date. If they're off, then a deputy is identified or another date's planned. Sometimes it can be a lengthy process, and so having an audit plan in place identifies when, how and who is responsible. Our admin support manages who is responsible to complete the audit and sends a reminder when it's due. So I'll just talk about the barriers. The main identified barriers to audit appear to be lack of time and availability of staff to actually carry out the audit. Often the immediate demands on staff time is prioritised over the longer term impact of audit for our patients. The environment is sometimes not conducive to carrying out an audit. We work around our patients and need to have protected time and space to fulfil our audit process. Resources are sometimes limited and this can be a barrier to getting the job done. Obtaining the data during an audit must then be analysed, which can sometimes be challenging. A lack of education and training in the audit process can be seen as a barrier to successful audit, as people often aren't equipped well enough in audit methodology. So just thinking about learning from our audits at St Gemma's, the best way that we found to communicate our findings are face-to-face usually in the moment. This can be either at team meetings or the inpatient unit meeting at the groups that I've discussed previously, or clinical leadership meetings, and cascade the information to who needs to know it. This can be backed up with minutes or notes from meetings and shared with those that aren't in attendance at them. We report all our incidents on the Vantage reporting system, which is where some of our audits are also done. Our clinical incident meeting is a monthly clinical meeting where all incidents are discussed and learnings identified. A face-to-face, in-the-moment discussion takes place regarding results from any relevant audits and any actions required, including re-audit if necessary. This information is then shared via a quarterly learning bulletin for all clinical staff. Pertinent info is sent via emails and communicated at handovers at the time. Repeated teaching sessions occur ad hoc as well as part of mandatory or annual timetable. So an example of this could be when there was an alert about the pink mouth care sponges that we used to use, that if they were soaked in water they would lose the sponge ability, and so we found that out. We changed practice, we sourced other products and then implemented them, provided teaching and retaught again, and so that it was part of everyday practice. Often issues are raised via the MHRA reporting system, and so a designated person is given the responsibility of investigating it further, finding new products, and then getting them out there onto the wards or wherever they're needed. So, to finish, I just wanted to focus on how we aim to sustain what we learn from carrying out our audits. So, a supportive organisational environment with involvement from managers providing a proposed audit plan makes for a good starting point. Including clinical staff at all stages helps to promote change if they're able and willing to help. Having designated well-equipped staff with protected time and systems that make data collection easier may help in carrying out the audit and analysing the data received. This, along with the ability to act on the findings and promote re-audit, helps to sustain audit as part of everyday practice. That's it. Thank you.
Hi there. I don't know about anyone else, but I have really enjoyed this Hospice UK conference. Thank you to all the organisers. There's been some wide variety of presentations and lots to take back home. Thank you for asking me to speak. Just briefly to touch on human factors in terms of patient safety. So my first experience of human factors was probably as an anaesthetist about 30 odd years ago, where I had different coloured, different font labels for each syringe when I was inducing patients. And this was so that in an emergency, if I needed a drug, I would pick the right syringe and do the right thing. My first experience of a significant event review, which probably made me interested in this forevermore, was also as an anaesthetist with a less positive outcome. I had a colleague who gave a caudal for pain relief after an anaesthetic. After a sequence of events, a Swiss cheese sequence, there was a child left brain dead. A parent of 3 children, the anaesthetist felt guilty for what he'd done. Couldn't cope with what had happened, or even the investigation afterwards, and sadly took his own life. And I think 25 or 30 years ago, we focused very much on individuals and blame rather than the systems. And after that time, there were a wide variety of books. This was one, Matthew Syed's Black Box Thinking, and if anyone's had a chance to read it, it's an excellent read. But in one story, they talk to Martin Bromley, who recounts the adverse event review for his wife, who again couldn't be intubated during an anaesthetic. There were 2 consultants trying to intubate her. There was an anaesthetic nurse there with the right equipment to save her, and the 2 consultants kept trying, and she thought they knew best. Time ticked by, and unfortunately, Elaine died as a consequence of that, leaving 2 small children. Martin was an airline pilot, and he struggled to see why the approach used in aircraft safety to report incidents and eliminate human factors in air travel didn't happen in the NHS. So he set up something called the Clinical Factors, Human Factors Group to support identification of human factors and enable safer practice. They defined 5 key areas of focus here, and I'll share some of my experiences alongside these. But there are other pieces of work that also have been really important in human factors. There's a website called Civility Saves Lives, and it shows that incivility has a significant impact, maybe not surprisingly on the poor recipient, and maybe not surprisingly on the bystanders, but surprisingly on the rest of that team who weren't even in the room, and also on the patient. And a rude surgeon, we know, apologies to the surgeons in the room, my husband was one, so I feel I can comment on this, can impair directly on the anaesthetist's performance, alongside inhibiting their ability to speak up. And that brings us to the individual. So one of the first main factors is enabling, and we've seen that from Vicky's speech around the freedom to speak up, healthcare professionals more than ever are at the sharp end and well placed to identify risks to patient safety. And what enables them to speak up is respect for relationships and culture. I've always encouraged and enabled a very flattened hierarchy in teams that I work in. I think that's crucial. Everyone has a part to play in patient safety and sharing information. And I always make sure that I thank them afterwards when they've made that brave move so that they do it again. In terms of prioritising safety, there's no doubt the current climate of workforce challenges is really difficult. And in CHAS, we've not averse to that either. I recognise it's easier to do in hospices, but I think we can, based on our leads who are skilled in this area, when they say they haven't got the skill mix to look after patients, they haven't got the skill mix. And we as seniors in the organisation need to be able to support them in that decision. And I think we should never forget that patients and families are part of my safety team. They are our eyes and ears when we're not there. They see things we don't see, and they have different perspectives. And by involving them in that process, it helps keep everyone safe. And again, thanking them for their contribution. When we review what happens, we need to look at what is right, not who is right. And I think as individuals, we often have variety in our practice. And it takes a lot of psychological safety and bravery to have a review of that and try and be supportively curious together to understand. And at the moment, there's no doubt there are competing demands for our clinical teams, and understanding those pressures for each individual in those teams. So we have to make up complex calculations for children's syringe drivers in a busy clinical room where there might be calls, etc. And like many others, I think, who have drug rounds with tabards saying, please do not disturb, we now have a do not disturb sign on our door just to make sure that they can do that calculation safely. Because by not doing these things, we risk significant moral injury of our teams and individuals if they can't influence the environment they work in. In terms of the team, how do we learn from previous events? Well, as my previous example showed, we tend to criticise individuals, and that can be damaging. So we need to focus on that psychological safety and be constantly curious together. For anyone who was here on Wednesday, I could have not done this speech because Jason Leach probably did it fantastically well. When he spoke of the impact in Scotland of implementing the WHO safety checklist for operations, where there was a staggering 36.6% reduction in mortality. It had not had that effect elsewhere, where implementation was done at speed. That was not a failure of the checklist per se, and actually Scotland's approach was a great example as to how to implement change well. In terms of debriefing and briefing, most places, including CHAS, use huddles to brief teams, identify risks and develop processes. Previously, after a child's death, we had a debrief process that wasn't really particularly productive. So we explored other alternatives, found an excellent approach in Grampian, got some training from Grampian, and now have had facilitated debriefs, which are much more effective support for staff, and also enables a route for thematic learning so that the organisation can learn too. I've got something here about unsafe behaviours, and I think it's really important when we have people behaving unsafely is to actually be curious and understand why. And then I think it's important as teams to develop an approach that focuses on team values, team behaviours and what we expect. So Clive Woodward did this very effectively with the England rugby team previously, where he used to say you can start the training at 9 o'clock in the morning and have a chat before, or the first half an hour's for chat. Don't mind what you do, but once we've agreed it, this is what we're going to do. And I think we could adopt approaches even from sports teams in patient care. And then I think it's important to recognise that situations of risk are best identified by staff, patients and families on the ground, and how we support them to do that. The board has a responsibility, and senior leaders, to have a key role in understanding human factors and engaging with the healthcare professionals. They need to help them identify things, but also help hold them accountable to enable that change to happen across the system. Non-compliance with procedures and policies, again, can reveal important safety lessons if you ask why. Focus groups can look at policies and procedures that aren't working. Why aren't they working? Are they accessible, usable, too long? I think we've all seen a few rather long policies that actually it's very difficult to remember what the key points are. And we're setting ourselves and staff up to fail if we do that. There's also things like policies on unacceptable behaviour and how we frame those policies and expect of our staff. And I think, again, when staff operate outside an SOP, there's maybe understanding the reasons and motivation for non-compliance. I think it'll highlight the complexity, but it will lead to safer processes moving forward. But a key area that I think is often forgotten are corporate services and procurement. So a key area of focus is to these support staff to recognise how their role affects safety. Cleanliness and infections, clear, well-filed notes, those are a wonder. Audits for improvement, as Laura talked about, and a good and fair complaint system which allows learning and better patient experience. Whilst I was an AMD for clinical quality and governance, I supported 2 patients with MND, one of whom was left in an emergency department on a non-invasive ventilator with his ventilator unplugged and low in battery and unable to ask for help. I can only imagine what that felt like. And I think it's really important to recognise that the staff would feel the same. It's just put him in a busy environment where they're not used to looking after patients who need that level of support. Again, is difficult for all concerned. And another patient given a buzzer to use when he was using eye gaze technology and needing total care. There's roles for IT. I think many of us probably have trouble getting access to all the information we need to have for our patient care. And we've already had talks today about data and how that helps inform safety. But there's a role in medical equipment as well. Why don't we just have one type of syringe driver or one type of whatever? That helps reduce the risk of dosage and rate errors and enables staff to operate well. And there's something about product safety as well. So you probably can't see those at the back, but those are 2 drug pots that look very similar, but have very different drugs. So there's something about system and product design that must take into account our human cognitive limitations and biases. New design should reduce reliance on human memory, especially mine, present critical safety information prominently, and prevent the switch off of safety warnings. Equipment should be piloted in the place of use and in a supported way prior to purchase. And there should be the strong brand identification that you saw on the previous slide should not override safety. So labels should be designed to prevent the possibility of confusion and reducing the risk of the wrong drug. And actually, when they're designing things like ventilators, it helps if the same button is in the same place. And I'm sure we've all had experience of that. So what are some tools that we could use to help us move to not always looking at what's wrong, but also looking at what's strong. And I think for those of you who've explored appreciative inquiry, it's just a very curious and positive way of exploring what goes well. There's something called humanising harm, which has been used as in New Zealand as a restorative approach for learning from events, addressing both the relational and the regulatory approaches. So it looks at who's been hurt and what their needs are first. It looks at who's responsible for meeting those needs and what their obligations are. It looks at how the harms and the relationships can be repaired. And then finally, how we can prevent it from happening again. And the final example is maybe human learning systems, which is a system that recognises that we are not a whole set of single systems operating separately, but a very, very complex system, both in the human body, in terms of disease, but also in the environments in which we work. And it allows public servants to be human, to create continuous learning, and nurture healthy systems. So that's a bit of a whistle-stop tour through human factors, and here's some links for more information. But it's obviously a crucial part of patient safety and helps us to create safer care. Thank you.
Wow, thank you so much, you three. That was absolutely fantastic. Any questions for the panel? Stuart, there's one here.
I actually put it onto Slido. It's just on there.
It's just come up. Perfect.
Yeah.
Do you want to just speak it out?
Yeah. So just in the context of where we've been with the pandemic, sorry, I've said the word, and and everything else, I'm really conscious that teams are running hot, not just in hospice, in primary care, in general practice, and just reflecting on human factors as an issue, and safety and patient safety. It's kind of trying to, how do we kind of recognise teams running too hot in the context of lots of work to do and trying to maintain resilience as an issue? Is that a patient safety issue? Is it an unsafe working issue? Culturally, how can we get the balance right? Sorry, lots of elements of the question.
I think that's a really complicated question. I think it is really important that we recognise and identify when staff are running hot, and part of that, I think, if you're a senior leader in an organisation, is being on the ground so that you can see people running hot. But I think you should also have some sort of data, either in a scorecard or a dashboard or something that gives you information about sickness. We have within CHAS access to various levels of support and well-being, including counselling. So obviously, having an idea of who is needing what sickness there is. But I think, to me, the biggest thing is actually to be on the ground and to feel that and be part of it. So I think for CHAS, we've moved well-being, which was number 8 in our plan. We've moved it to number 1 in our plan, because without having healthy, well-supported staff, a building is just a building, a service is just a service. If you've got well-motivated, supported staff, that's where you get the gold at the end of the rainbow. But I think, having come from the NHS not that long ago, I recognise that, they, as much as hospices, are in a very, very difficult position, and people leaving. And so it is about trying to turn that tide one person at a time, and making a difference to individuals. Don't know whether...
Yeah, I think communicating with the staff, and I'm on the ward quite often, and temporary things that we did during COVID were reduce our bed numbers on the inpatient unit. If we had loads of sickness, which it was sort of up and down like that with sickness, it still is, and recruitment, and we were lucky to recruit within the pandemic, and so we are more or less up to our established amount of nurses and healthcare assistants. But listening to them day by day and sort of working out the acuity of what's happening on the inpatient unit allowed us to know whether we could take however many admissions, what the capacity was on the IPU. The capacity was higher in community, so a few of us worked between the two. It was a difficult time, but even just reducing our bed numbers by a couple helped the staff that were working. But like you say, being around really helped.
Thank you, guys. That's really good. You're really responsive, Flora, there as well. So that's, very responsive. There's a question on the Slido that's somehow archived, and it's for you, Vicky. I wonder if human factors has been part of your patient safety strategy and training.
No, but it will be. I've learned an awful lot today.
Yeah, perfect. That's great. Is there any other questions on the floor? Nope. It just leaves me to say a huge, gigantic thank you to you guys for presenting your information today. It's been sorry, I'm standing away from the mic. It's been absolutely really interesting, absolutely fascinating. Thank you very much indeed. Thank you for you guys for staying, coming to our session after lunch, which I know is the kind of graveyard slot, but hope it's been worth your while. Thank you to Stuart. For those who are part of the patient safety community practice, you'll know Stuart. He's the man that fixes things. Oh, and there's another couple of questions. Sorry, you can't get away just yet. From Tom, any tips on communicating risk tolerance, positive risk taking around clinical decision making to non-clinical staff trustees? Who wants to answer that? Sorry, everybody.
I suppose we meet regularly with our board and have had quite distinct conversations about this. I think we're lucky in Chas. I think our board are very keen to learn, very keen to understand and recognise the expertise in the room in terms of we bring quite a lot of our team to our board meetings so that they can hear it from our staff. But I think there is something about if you are in a, and we're all leaders at every position, but I think if you're in a director type role, there's something for me very important about you enable the staff, but sometimes you have to take the pressure that comes from that. I don't know whether that answers it.
Thank you. There's just another question from Margaret Mary. I don't know who that's directed to. You're in the audience. Hi. To Vicky. Sorry, Vicky. What was the membership of your patient safety team? And I've lost it here. What was the membership of your patient safety team? And what was the agenda ultimately after several iterations?
It won't surprise you that the membership changed really at every single PDSA cycle, and we kind of worked through lots of different versions to get it right. I think the real challenge for our patient safety structure was that when it started as a thing, as a forum, it didn't quite fit into the other meetings within the organisation, and that became quite evident as we moved on. So certainly as we moved through the system, moved through the cycles, and we added falls and pressure ulcers, our group membership changed, link staff, our physiotherapist. The key thing for us, these groups were meeting elsewhere in the hospice, but not necessarily with the patient safety remit. So membership was quite different as we got to the end.
And I think it's just a question about what was the TV show hinted at.
Well, yeah. So for those who watch The Chase, the governess, so I was very tempted when we were having discussions in the team about it. I wanted to be Mary Poppins because she was a governess and practically perfect in every way, but my team were having none of it and had me as the governess on The Chase. So, yeah.
I think there's a question from the floor here, and sorry, I'll come to you in a sec, Stuart.
Hi, I'm one of the physiotherapists from St Christopher's, and my question is around how do you balance in terms of risk averse with risk confident in terms of managing patients' goals as well, of like falls, for example. We had a case where we went to visit someone in a care home where they were kind of prohibited to do the stairs, and her goal was actually to be able to manage the stairs to go home. So how do you manage those things in terms of cascading to the clinical staff? Because I think there is something about being risk confident as well in terms of managing the risks, but also not only on that being risk adverse front of side of like avoiding all risks. How do you kind of train and manage that with the clinical staff? Thank you.
I used to work with a great geriatrician who used to say, if you've got no falls, you're doing everything wrong. And actually, what you want is what you should see is a certain number of falls without harm. And by that, what you're doing is you're mobilising, you're encouraging, you're developing, and you're accepting a certain amount of risk. And that's obviously linked to people's goals. But if you are not seeing any falls, it probably means you're tucking people up in bed who actually need to be mobilised, and the significant risks of that in terms of getting them home and them reaching not only the goal of mobilising, but actually much wider personal goals as well.
Thank you, Annabel. One more, yep.
Thank you. Mark Hazelwood from the Scottish Partnership for Palliative Care. Thanks to the presenters, it was really interesting. It's not a field I know anything about, but it's been great. I just wondered if there's work done looking at harms which are essentially psychological or spiritual. A lot of the examples were things which were likely to have kind of be essentially physical and biomedical, albeit they might have spiritual or psychological consequences for people. But are there things that people looking at patient safety look at as triggers and to work on, which are about kind of non-physical dimensions?
I don't think there are, Mark, and I actually think that's a really wonderful... I think we often think that patients don't achieve their goals because of perceived harm, of physical harm, but because we're not good at quantifying existential harm, we don't balance that scale, and therefore there's always the physical harm that seems to count for more and is measurable. So I think that's a really wonderful thought to take away in terms of how we can all think about how we would measure that to help us have the right risk balance. Don't know what anyone else.
I mean, yes, I just want to pick up on that. I think it's really important that we do look holistically at the person, and that is their spiritual and their mental well-being as well. And I think sometimes the mental well-being does come into it because, you know, you don't want people that feel underconfident, especially if they're going home. You don't want people wrapping themselves up in cotton wool either. The spiritual aspect is something I actually haven't thought of, so that's a really important question, so thank you.
I'm not sure that we report them, but I have a slight example of this. So we're really good at reporting pressure injuries, drug errors, all that kind of stuff. And just last week, we, as the senior nurse, you would hold a nurse in charge phone, so you'd get outside inquiries ringing. It could be for anything. And it was about 5 o'clock on a Friday, not last week, and somebody rang that was attempted suicide. So it was an external, it wasn't one of our patients that we know, it was somebody ringing with a cry of help, and it just happened to be me that answered the phone. And so I did actually report it because I needed to hand it over in case there was any calls again over the weekend, and there was. This person wasn't known to us, but had also attempted suicide the Wednesday before ringing me on the Friday, and then rang again on the Sunday, dying of a broken heart, is what they told me on the phone. So I obviously did what I needed to do from my part, but then just logged it. I didn't put it on a Vantage like our incident report. I just put it on the manager's log and then the nurse in charge log and handed it over just in case. But I suppose that could have, I was a bit like that whether I report it on Vantage, because if I do, we then discuss it, and I probably will discuss it again. And I discussed it with my manager at the time. But I'm not sure we capture all of those sort of things.
And there's not only the harm, I think, to patients, but there's also the harm to staff. And obviously we do understand a lot more about moral injury and harm to staff now, but that is part of our human factors and risk safety approach.
A great question, Mark. Look at all our brains just like ticking along. It's fantastic. Are there any other questions on the floor? Yes, one. Yep.
Sorry, it's just picking up that issue around moral injury, and I suppose there's two types: patients or even carers, and then staff. When you say we know a lot more, what is your sense that we know? What's changed that we know, or what can we do differently to assess and manage moral injury or burden? You know, I know in the Oak suite of measures, for example, the Zaret burden questionnaire used to be there, and it's sort of not something that we really, doesn't really seem to have followed through into its application that much anymore. Sorry, I keep asking too many questions with too many facets.
We don't use that. We use the Oak measures, but we don't use that. And yeah, it did. I remember. Now you've said that, I do remember that. But yeah.
Moral injury issue for our staff. How do we measure it? How do we manage it?
Yeah, and I suppose some of that is observational. Some of that is through what we hear, what in terms of sickness, access to wellbeing support, things like that. But also I think being very mindful about processes that we create and hopefully co-create that actually enable the staff to lead that from a well-being point of view and a moral injury. But I think it's always having that human factors approach of, you know, what are the unintended consequences? How can we make this right for all groups? And I think that comes back to policies and procedures. You know, I think we've all seen policies and procedures that go into 25 pages. I have to say I'm menopausal now, so the thought of trying to remember what's in 25 pages is slightly disconcerting. And we've got hundreds of policies in most health boards and hospices, etc. So for me, you know, so one of the things we did during COVID in the borders was we changed our unitary patient record on admission for all patients coming into the hospital from a 40-page document to a 2-page document. Because what we said was that we'll trust the staff to fill in what they can, depending on, obviously we weren't quite sure how many patients would be coming in with COVID, but we would trust the staff to do any extra assessments, Waterloo, anything like that, that they needed to do based on their assessment, and encourage them to think rather than tick box, and actually go back to empowering them to lead that. I have to say, I think I've left NHS boards now, I think it's snuck back maybe to the fuller document, and I think that's the really difficult balance that we have to have a conversation with register, you know, sort of services that oversee our services, to sort of have that conversation about, you want to see X, Y, and Z, but actually, how can we enable the maximum time for people to care? Because that's what our patients and families measure us on, and is their version of what good looks like. But we need to be able to show that as well, and it's how you show that without taking too much time away.
We are coming to a close, and again, thank you so much to our panel, wonderful panel. Thank you to you guys. There's one session left in the Lomond Suite, I believe. Thank you all. Hope you enjoyed your conference. It's been so nice to see so many people, and look forward to seeing you all soon. Thanks for coming.